in essence, and the well-being of everyone and being united and joined together. So, tū taua mai I runga, tū taua mai I raro, tū taua mai I waho, tū taua mai I roto. Kia tau au te Māori tū, te Māori ora ki te katoa, haumi e, hui e, tai ki e.
Okay, thank you, Helen, for that karakia. Welcome everybody to this session this afternoon. Please just be reminded that it is being recorded. My name's Barbara Purdy. I'm in the Taranaki Locality Office. So it's good to see everyone here. I'd really like to now introduce Helen Parker, who is doing the presentation today. Helen Parker is our CEO of Pinnacle Midlands Health Network. And I also understand she is a very good saxophone player. So we will be looking forward to hearing that later on.
Yeah, I think I'd rather be playing my sax to you all now than taking you through a session on funding. But,
Okay. So just a few things that Helen will cover off is overview of the vote health, the budget given to the health by the ministry, how it's formulated and allocated, how it flows through the system, how we allocate PHO funds to practices, locality views of flexible funding, and what's coming in on the horizon. So many thanks, Helen, and it's over to you.
Kia ora, thanks, Barb. And thanks everyone, I genuinely mean it. Thanks for giving up your lunchtime, and I hope I think is this the second or third session? I hope you're enjoying it and it's meeting your needs. I joke a bit about funding and finance because I will confess it is not my chosen area of expertise or most favorite topic, and I have to really apply myself when I'm at the finance meetings, but it is obviously really, really important that people understand how funding flows, because it drives a lot of the politics of health, in terms of what we value or what funders value, and actually then how you can actually deliver healthcare to our patients. And I guess what you're particularly interested in is then how does the money from the PHO flow to practices, and how is that decided and how is that allocated? And I know there'll be various levels of understanding amongst you all on that. So I've sort of taken the view of assuming that you know nothing. So I apologise to you for that, but I know that there are some people for whom they really wanted a good overview. So I'm going to spend a bit of time on the national stuff because it's important and will become more important over the next couple of years when we're looking to go through, particularly now we know Labour's been elected, we're to go through a health system reform and restructure. How the funding flows is going to actually become very important and a target for reform. So understanding where we are now and where we might move to is good, and also so that you can support staff in that as well. So I'll try and make it interesting. And I think probably the first time I'm very, very keen that how we fund practices and what for is absolutely transparent. So, when I came into this role, and of course I was aware of it slightly before, that a lot of practice managers and the GP owners weren't quite sure what money came in, what money the PHO kept back, and what money actually came out to practices. So we've been doing some work, and sometimes it's difficult to untangle some historical finance flows, which I'm sure some of you will be aware of just at the local practice level, but we've been spending some time doing that. So I'm going to present a locality level of how we do allocate our discretionary funding so that it's absolutely transparent. So I'll just share my screen, but just before I do that, just stick your hand up if you feel that you know very little about how funding actually flows through the system from the treasury down to general practice. If you're less than 50%, okay. That's good. So it's obviously why you're on this Zoom, of course. So I'm just going to share my screen.
Oh, were you enjoying the audio yet or visual? Do we want to?
Go to,
How come it's come up? Oh, she's sharing her screen. Oh.
yeah, so just put yourselves on mute if you're not going to join in the presentation. And I, you know, some of you who know me well know I hate presenting like this. I prefer to present in a room full of people where we can have an interactive discussion. So, but I will pause a couple of times and take any questions that you've got before moving on. So we've just been through that. Barb's just given a session of what we're going to cover, and I hope what comes through is you'll know this intuitively, but maybe have a bit more background knowledge as to why actually primary care is such bloody good value for the funding that we get. And hopefully I'll be able to make your sort of dry topic seem quite interesting for a lunchtime session. So the New Zealand health budget is called Vote Health. So if you hear people referring to Vote Health, it is actually referring to the total budget that the Treasury allocate to the health system. And that budget is announced annually every year, and we're talking the bit that's funded via general taxation. So everything I'm talking about today does not include ACC, and it obviously doesn't include the patient co-payment. It's just what comes down from our taxes and from the Treasury. And since 2003, it's been based on a population-based funding formula. So DHBs and PHOs are actually based on the number of people that are either in the DHB district and aligned to that DHB or enrolled with a PHO. And the Ministry of Health used that population funding formula to agree how they're going to allocate the funding down to the 20 DHBs. And actually the money that goes down to the DHBs is about 75.5% of the total budget. I'll take you through a bit more of that in the next slide. And then the allocation that each district health board does receive is also determined and weighted by ethnicity, sex, age and relative deprivation, so the quintile score. And then they also use adjusters for diseconomies of scale. So the smaller DHBs will get a little bit more, and also related to rurality, how many overseas visitors and international students, for example, that they have to serve, and some of the unmet need that's identified. And actually why health is so political is, and why we will never remove politicians from it. Oh, I'm just accidentally touched my screen. Is because it is one of the single largest budgets that the Treasury allocate, along with education. Some of us are a little bit sceptical in, if you look at the Health System Review, where they're talking about setting up Health New Zealand and removing the operationalising of the health system a little bit further away from politicians. In my experience, that never happens because of that reason, because it is so much of our taxation that goes into health services. And this year, 2020-21, Vote Health was $20.2 billion. So not insignificant. So my next slide, I'm just going to take you then how that $20 billion flows through the system. So Treasury, along with the Cabinet, so they'll start thinking about this in the next 2 or 3 months in preparation for next financial year, will start having discussions about how they're going to allocate funding across public services. And then the Ministry of Health will be informed as to what that Vote Health budget is going to be for 21-22, probably early next year. Out of that funding that they get, the Vote Health budget, some of that will remain at the ministry and funds those national services that are funded nationally. So like the blood service, like some maternity care, like disability services. And there's lots of other services as well, which are funded and managed by the ministry. So about 75.5% of that budget from the Treasury actually goes to the district health boards. And from there, the district health boards fund their hospitals, their DHB community services, NGO providers like our Māori health providers, some public health services, aged residential care, pharmaceuticals, and some other stuff. I couldn't list them all. And then it also distributes the funding to PHOs within that district based on the population-based funding formula. The funding that the PHOs receive from the district health boards is, the first group of funding is we get a PHO management fee, and I'm going to go through these in a bit more detail. We get funding for services that we directly provide as a PHO. So we have contracts with the DHBs to do that. We get rural funding based on our population that live in designated rural areas. And we get performance funding based on our delivery against health targets, which is why our payment to practices on those national health indicators is based on performance, because the funding we get as a PHO is also based on what we achieve and what we don't achieve. We also, of course, receive from that capitation, which goes straight through the PHO directly out to you as practices. And most of our discretionary funding is called flexible funding, which used to be the sort of services to improve access, Care Plus, health promotion. It's all wrapped up into one now called flexible funding. So that's basically how the money flows from the Treasury down to district health boards and then to PHOs. Now this is an interesting graph. This is 2017-18 because there's not a more recent graph like this, but the actual numbers aren't too important. It's the relative proportion of funding. So if you look at my first arrow, that proportion of the total vote health funding is how much goes into DHB hospitals and their community services. So that's provider arm spending. If you look at my second arrow, that is the proportion of the DHB funding that goes to PHOs for all those streams that I've just said in my previous slide. So you can see that the proportion of funding for hospital and DHB community services compared to the proportion of funding for PHOs already presents as a problem in terms of how much is allocated to primary care for what primary care is expected to do. Now, I know I'm preaching to the converted because you all bear the brunt of this, as we all do, in that what is expected of primary care in terms of its contribution to the health system and what proportion of funding actually comes to it. So capitation, for example, will be a very small bit of that total PHO spending. It's out of kilter, isn't it? And we all know that. I guess what I'm interested in is how many of you understood that the proportion of funding to PHOs compared to hospitals was that stark. Did you all know that, or is that relatively new information? And it's quite stark when you see it like that, isn't it? When you see the proportion of funding. So it's actually about 5% of the funding that goes to DHBs comes to PHOs, which is not just obviously for general practice services, it's for other things that PHOs provide as well. Has anybody got any questions so far? No? Just show my screen again. And it's one of the reasons why we're spending so much time hold on. Oh, now you can also make. Why we're spending so much time on advocating for a primary care spending review, but also advocating at a national level for some very honest conversations about what is expected politically of primary care and whatever may replace PHOs in the future, compared to the proportionate amount of spend on it. Because when you see that, it absolutely shows you why the sponge is full. You know, some of you will have heard me say this before, that primary care has absorbed a lot of additional demand, a lot of additional complexity without the funding to go with it, and that sponge is full. And therefore, if you read things like the Heather Simpson report that's saying primary care should be doing more of this, could be doing more of that, could be doing more of that, is absolutely true, but not with that little small bit of the pie. It also, going back to what I said before, it also starts to show you about where we're placing the value of a health system, which is much more about people getting sick and going into hospital, as opposed to supporting people to remain at home and to keep them healthy in the first place. So what I'm going to talk about now is the PHO funding. And those streams of funding that we were talking about. And the three main ones that come into the PHO is the PHO management fee, which ranges from about $5.60 to $6.30 per enrolled patient with the PHO. And that varies because it's based on that population funding formula. And so in some of our districts, we've got a higher level of MARI, for example, and deprivation in some of our DHBs, so we get a higher management fee. And it equates to about 3.2 million. And out of that PHO management fee, we fund everything that it takes to run the PHO, really. So staff salaries, our buildings, our infrastructure, all our offices around the network, we need to make sure is funded through the PHO management fee, because that's not intended for patient care. It is for the running costs and supporting the PHO. So it covers things like our boards and governance. I'm just saying, has someone got a, it's difficult when I'm just seeing if someone's got a question. Yeah. Okay. The flexible funding is really the big, the pool of money that a PHO gets, which is to support patient care, and is where we have a little bit of discretion as to how we spend that. And I say a little bit of discretion because in every DHB district, we have to agree a flexible funding plan with the DHBs as to how we are going to spend that flexible funding. So it's flexible within some parameters, and I'll talk a little bit later about where we think that's going to go in the future. So it's population based, it's weighted for age, quintile and ethnicity. And that is for agreement around what are our health needs, what's our strategy, and that really is the funding that we can use to support delivery on our strategy and to ensure that patients are getting the right care in the right place, and that the patients that need the care most are getting that care. And as you'll have seen from the previous graph, which is why I showed it to you, it's not actually a huge amount of money when you look at the need that we should be meeting, as well as ensuring practices have got funding also to be able to provide the level of care that you need to over and above the capitation that you receive. So I'm going to talk a bit more about the flexible funding in another slide. And what some of you may not realise also is that the PHOs, most of them, not all of them, are actually provide quite a few services themselves, which is not related to general practice services. So Pinnacle has this year 88 contracts with our 4 DHBs for a wide variety of service delivery on which we receive funding to deliver on those contracts. So I've just put some of examples on that. So it's primary options in the Waikato. We run the school clinics across the Waikato, sexual health, support to screening, mental health, brief intervention for smoking, diabetes, and I wasn't going to go and list the whole 88. So as well as our support to general practices and the funding for general practices, we also actually manage and deliver on those contracts. Now, why this is also important in terms of understanding, because I often get a lot of questions from practices, quite rightly, and very, very good questions, is, how do we afford to, for people to go off on training courses? How do we afford to spend money on industry? How do we afford to do some development work? And does that money come out of funding that should have gone directly to patient care? And the answer is no. What's happened with Pinnacle over a number of years is that we've delivered on those contracts, and on some of those contracts we make a surplus. And some of that's because of our scale, and we're able to be very efficient from a management perspective, because we get a project management fee for those and a contract management fee that goes along with those contracts. And when we make a surplus on some of the contracts, we have to agree with the DHBs how we're going to reinvest that the following year, and that's called a wash up. For some of those contracts, we don't. And in the past, what we've done is, where we've made a surplus, we've put that into what's called we call it Pinnacle Reserves. It's like a Pinnacle savings account. And over the last few years, I'll go say 10, 15 years, that account started to build up, which is why we've been able to invest in doing other things that other PHOs haven't been able to do. For example, like the design and development of industry, that wasn't paid for out of any flexible funding money. That's been paid out of surpluses that we've made on contract delivery. The other important thing to understand is that actually, as DHBs have started to move into a deficit model, there has been a big shift towards the wash up and reinvestment of surplus into other services, as opposed to the PHO being able to keep any profit that they make on those services. So the ability for Pinnacle to build up that savings account again is going to be much more limited, which for Pinnacle means that we've got to be much more careful now about what we spend any surpluses or savings on. Has anybody got any questions about that? And I'm going to stop sharing my screen because it's a bit complicated to go back. But has anybody got any questions on that? Or I can take them at the end if that's easier. So I do labour that, because often some of the questions I do get is, well, where does Pinnacle get this money from, and is it money that's coming from practices? And it's all come from surpluses from contracts that we deliver directly. So my next slide is what we've been trying to do to make it much more transparent to you as practices as to how then we allocate that flexible funding. So what I've set out here is our budget for this current financial year. So each DHB district obviously is slightly different in terms of there's a flexible funding that comes from each DHB for that district, and so we can't use Tairāwhiti flexible funding, for example, to support something in Lakes and vice versa. We have to, as I said before, agree each flexible funding with each of our DHBs. And in essence, the flexible funding funds three things. Money that comes to practices, which we call capacity and coverage. Some of it was called innovation funding after the previous couple of years in a couple of our districts, but it's essentially called capacity and coverage and comes directly to practices. Secondly is the quality plan funding that supports that achievement, the national indicators, the service system level measures, which you receive, which is on the back of the quality plan. And then the third bit of funding is the funding that we use on behalf of practices in each of those DHB districts to provide access for patients to services, and is often used so that each individual practice doesn't have its own tiny little bit of that proportion and then have to buy those services on behalf of their patients, but actually we can provide it on your behalf and you can just refer. So things like to the extended care team roles. So you can see, if you take the first column, the proportion of that flexible funding, which goes directly to practices in one way or another, is set out like that. So roughly the same for Lakes, Taranaki and Waikato. Tairāwhiti, it's a bit higher this year because what we're doing is running a Māori equity project through the practices this year and seeing what impact that has on Māori health, which is why it's a bit higher for Tairāwhiti. And just be aware that whilst it's fairly similar, it doesn't mean the dollar amount is exactly the same because because of that population-based funding formula. 61% of lakes could be slightly different from 63% in Taranaki, but that's in essence how it's panned out across our practices in the network. It also funds some third-party after hours. So, for example, in Taranaki, rather than practices funding additional services after hours for a high needs population, we're funding things like in South Taranaki, St John's See and Treat, to provide better access for those high needs patients after hours. So it includes some of that as well. And I'm really happy to take some questions on this later. So the next column is actually the bit of the flexible funding that the PHO uses in-house, and that, as you can see, that's a very small proportion of the total flexible funding pool. And that funds things which indirectly supports better patient care, which actually other PHOs don't do and can't to the same extent. So things like Power BI, where we're looking at really developing the data analytics, the data informatics to inform better decision making, better service provision for patients. It funds some of that work, and things like the Power BI licenses. And so it funds a bit of the infrastructure in the PHO, which we say actually without that, it's really difficult to even plan and support practices to deliver better patient care. So again, often people will say to us, and we do use some of the PHO management fee also to support some of that, obviously, but that is the level of flexible funding that goes into that. The next column is that bit of flexible funding which we use to indirectly support patient care. So that's funding, for example, and you know, some PHOs don't have this, is the nursing leads, the nursing education, the GP leads, project management. So things like the project management, for example, that we're looking at now around, should we be providing a virtual GP service to our network after hours and to their patients, looking at developing an online e-consult tool to enable patients to do triage at home, as opposed to having to ring or go and see their GPs and getting some support. Things like, should we do support remote monitoring? Should we do the ultrasound? All that sort of thing that, yeah, it's not direct patient care, but it does support actually looking to the future and how could we provide better access to care. And things like accreditation assessment and supporting practices so that you don't have to fund that yourselves. And then another proportion of the flexible funding is that number 3, where we actually use flexible funding to provide services. So in Tairāwhiti, for example, we've got clinical pharmacists, social workers, nurses in the extended care team, and in Lakes and in Taranaki, which practices can refer to as many times as they want to, as their patients need it, and they've got access to those services. In Waikato, that's a little bit more difficult to do because of the geography, but actually we're starting to look at and starting to put some of those extended roles into our higher needs areas. So for example, we've got the clinical pharmacists in Tokoroa, we're going to be putting some into North Waikato and Huntly. So it's using that flexible funding. You know, some people say, well, that should all come down to practices. Well, you could do that, absolutely, but then the proportion that each practice would get would be quite small, and you'd quickly use up your little bit of it, whereas actually being able to refer to other professionals in the network and things like some of our mental health services enables everyone to have a bigger slice of the cake. And then some of the flexible funding has been in supporting some of the healthcare home development and PAC. And the reason that you see it's so little in Tairāwhiti is that we don't have any practices using the Patient Access Centre. All of Lake's practices do a little bit in Taranaki and Waikato, and that's because that's improving access, telephone access to the patients enrolled in those practices. So I know that's quite a lot of information. And I think this may be the first time that you've had this level of breakdown of flexible funding to practices and how the PHO allocates it. And this is the budget. So as you all know, at the end of the year, we might have overspent, depending on number of referrals and quality plan, things like that, or we might be underspent. So those keen numerical people amongst you will know that those percentages don't always add up to 100%. And where that is, it's because in this year's budget for flexible funding, we're using some unspent money from last year and allocating it into a budget for this year. The other reason that we sometimes have underspends is because some of those project development or service development, particularly around extended care teams or staff for the MRI clinics, we don't appoint staff for the full year or when we've budgeted to appoint them. So there's always a bit of a surplus that we then reinvest in the budget for flexible funding the following year. In Waikato, actually, we are overspent in flexible funding, and that's largely been an increase in referrals around diabetes and mental health. So we're just managing that with the DHB. And then my last slide before we get on to a bit of a discussion and any questions around what I've just presented is what's on the horizon. So what we do know, so if you look at that flexible funding and how we've allocated it, what we do know is, and now that we know that we've got a Labour government, is that, and we've been feeling this for the past year or so, is that there's a much more scrutiny on that flexible funding being targeted, the majority of it being targeted at Māori health equity. The implications of this, of course, is that if you're in an area with low Māori population or you're a practice with a very low Māori population, the ability for us to allocate funds equitably across our practices is reduced, because when we're getting into discussions with DHBs about how we're planning to spend the flexible funding, we're having to demonstrate that most of it is going to go towards Māori health, and we know that's a big priority of the Labour government, and they're going to be saying to DHBs, all the fund, a lot of the funding that's coming your way needs to be targeted at where it's needed most, and that's around addressing Māori health equity. So the politics of the funding we've started to feel already. I think it's going to increase now with Labour getting a second term, that the flexible funding is going to become flexible within the parameters of it being addressed to Māori health equity, or at least and populations with a high level of need. I also think that with cash-strapped DHBs, so each DHB has been told they've got to get back into financial balance over this financial year and the next financial year by the Health Minister. And again, because Labour's in for a second term, that's going to continue, that we're getting a lot of noise that there's going to be not less investment in primary care whilst they're getting back into financial balance. So where we've been able to lobby DHBs for additional funding over and above what I've just presented, I don't think we're going to be seeing that well, we're certainly not seeing it this year, and we won't be seeing it in the next year. I think also, and again, with the Labour government coming in, I think we might see a potential disruption in current funding, for example, things like vaccinations. So what is being talked about a lot is how Māori health providers and iwi mobilised themselves during lockdown to ensure that their Māori communities were receiving vaccinations, particularly the flu vaccinations, and how successful they were at it. And this has captured the interest of both DHBs and the ministry, and looking at, well, maybe in the future we'll be much better putting our funding, for example, around vaccinations into Māori health providers as opposed to traditional primary care. So there's been no agreed decisions about that, but these are some of the discussions that are taking place. And what Labour have promised as part of the health system review is a comprehensive primary care funding review. So if you go back to the graph that I showed around the proportion of how money is spent from the DHBs, this is going to be absolutely critical, I think, for the future of general practice. And as some of you will have heard me say in other forums, we are lobbying for a review of capitation and the funding that goes into capitation, and also a review of additional funding into general practice and to community services that support general practice. So that, as I said earlier, it's probably going to be one of the most critical things that we will get involved with in terms of our advocacy. And before, my last thing is, I can't share with you any quotes about primary care from the health system review because there was only 5 mentions. But the New Zealand Health Strategy in 2016, which is still being talked about in national levels, said, among New Zealand's strengths is a publicly funded universal health system and health services with a strong focus on primary care and widely supported focus on wellness. And we are holding that up as a mirror to say, if this is what you actually think, it's got to be funded proportionately. And I know I'm like a broken record on this, but you will know as well as I do that there is now a limit to what general practice and primary care can deliver on without us having a complete review of how the system is funded. So I'm going to stop there because it's a lot of information. And you may or may not have questions about that.
Can I ask a question?
You can ask anything. Ask away.
It was just to get some clarification about the slide where you showed the percentage of flexible funding that goes to the different areas. So I thought that healthcare homes and PAC funding was user pays.
It is. So some of it is.
Why 4.8% in Waikato is funded by the PHO?
Through flexible funding, and that's true. So all the practices that use PAC pay a proportion of the funding for the use of PAC. We needed to get some scale for it to be for it to become totally funded by the practices, which we haven't achieved because not enough practices have said they're going to use it. And also, it's a number of the practices that use PAC have high Māori and high need populations, and therefore we felt historically, so that's a historical funding, that it is supporting improvement of services to increase access to those patients. And any Pinnacle practice can join PAC. But it's a very small proportion. It's a, you know, if you look at the total PHO funding in that graph, take out capitation, take out all the money we get for our 88 contracts, take out the PHO management fee, take out capitation, it is actually the flexible funding in each DHB district is a very small amount of money. So then if you take the small percentage that actually we're putting into PAC at the moment to improve telephone access to those patients, it's a very, very small proportion. And if we spread that out over all the practices, it would be minimal.
Helen, I thought PAC wasn't funded anymore, because we were looking at going over and we were told that it wasn't. Sorry, it's Candice.
Oh, okay, in the column room.
Yeah, I thought we were told that PAC was no longer funded.
When you say, what do you mean from the PHO?
Yeah.
It has a very small amount goes in from the PHO. Yeah.
I'm confused.
But it's small, but I'm putting it up because as I've said, I'm going to be absolutely transparent about where we're allocating the funding.
And I just had another question, and this was to do with the vaccinations.
Yeah.
Just get some clarity around that. So as you know, we're a practice with a very small Māori population. Yeah. And so, yeah, I'm just wondering what that means for practices like us who have, you know, a very big vaccination program, particularly around flus and things. Does that mean that we're going to lose quite a bit of our funding? Like, is someone else going to come in and do those vaccinations? How does that work?
So let me be absolutely clear. There has been no decisions made about this. So I don't want you all to go out and say, oh my God, general practice is going to lose all its money for vaccinations. That is not what I'm saying. But what I am doing is being honest with you about what conversations are happening. So I think, and this is where, you know, we had this discussion at your practice, didn't we, Wendy? I think at one level, if you're a practice that has got a very small Māori population, I think how we can target flexible funding to those practices will become increasingly limited because we have to show that we're targeting to Māori equity. On the upside is actually if you're a practice with a very small Māori population, you probably won't be as affected by a potential shift of vaccination services to Māori health providers, because they potentially could have the contract for delivering vaccinations to Māori patients. So actually you then wouldn't lose out so much.
That makes more sense now. Thank you.
Yeah, but there hasn't been any decisions made about this whatsoever. All I'm saying is what has been recognised by DHBs in the ministry is that during COVID, when Māori health providers mobilised themselves in their communities and set up vaccination clinics, they did very, very, very well at getting and supporting their whānau and their community become vaccinated. In a way, we have to say, in general practice, we struggle. So if you're looking at it from a population health perspective, you would start to say, well, maybe that's a better way then to do, to provide those sort of services. So maybe we'll contract that out to Māori health providers. Any other questions? Does that make sense? Because at one level I've simplified it because it's actually quite complex, and to put all the funding streams and every little bit on it onto a slide will have bored you to tears and have been quite difficult to do, but I wanted to give you enough so that actually you could make sense of it.
No one else has got any questions. I've got another one. And that's just around innovation funding. So there was a change this year to that being put back into, you know, long-term condition funding. So what's the thoughts moving forward in terms of some of those pockets of funding that you were giving to practices if they had some initiatives, etc.?
So that's tied up with the discussions that we've had around the quality fund. So that all that is just a different label for different bits of flexible funding. So all the innovation comes from that flexible funding pool. one of the problems that we had was, and this goes back to us having to agree with DHBs how we're spending that flexible funding, which sort of irks me a little bit, but is that we were struggling to demonstrate the outcomes that had been achieved using the funding in that way. So what we did to ensure that we didn't remove any funding from practices, because that's what we would not want to do, is we've sort of rebadged it back to capacity and coverage long-term conditions, to say, well, actually, we're just funding practices to do care really well for their population that they serve. We still need to be showing some good outcomes. And we'd want to do that anyway, to be honest, whether it's DHB requirement or not. The moving forward, so we have had some discussions, and we had a lot of these at the cluster meetings, is do we use the flexible funding in the quality plan to fund little bits of target driven care, or do we shift to a bigger proportion of that funding that sits within the quality plan to giving a sum to practices to say, let's just agree what you want to do with this sum and what outcomes you're looking for, which is sort of what we're doing within Tairāwhiti. We're saying, actually, this was innovation funding. Now let's target it to Māori equity, because that's the way we can keep it in general practice and not remove it. And say, let's look at what outcomes we're looking for, which they're going to use to target their enrolled Māori who don't attend general practice. And do we move the quality plan to being more of a less against each line of a target and more flexible funding to you, if you like. And those discussions will be had over the next year as to what the quality plan looks like next year. I have to say, having discussions in all the clusters, there seemed to, I was expecting a lot of people to say, actually, we'd like to move to it all being just one lot of money and let's just agree how we use it, to actually, we quite like the quality plan. We quite like it being targeted. I mean,
not us.
I mean, immunisations, I'm quite keen to move away from incentivising immunisations for a couple of reasons. One is, the ones that you'll know really well, is that the money that you actually receive, and you can see why it's such a small proportion of money, because it's a small proportion of a very small bit of pie anyway, and the work that you have to put into getting it is disproportionate. The nurse time, the admin time is disproportionate. So I think we can use that funding better. And also, I have to say, we're the only PHO that does that. And we're not at the top of the league tables on immunisations. We're in most of our DHB districts now, we're in the middle or in the bottom half. So actually, you have to say, what does incentivising immunisations actually do?
Yeah.
Do you know why that is? Why are we so low in our performance? Is there a reason for it?
Well, there must be, because you know, a lot of other PHOs get better results than us. I mean, we're not bottom. I mean, it's the one thing that keeps me awake at night, if I'm honest, is over the last couple of years or so, we've moved down the league tables a bit in those national health indicators compared to other PHOs. I don't know. You tell me. I think I don't know, maybe in practices just taking our eye off the ball a little bit. I think, you know, we know some of the problems with immunisations that, you know, if you're a small practice and you've got a couple of declining families, that's going to affect your stats. But then other PHOs have that as well. So I don't know. What do you think?
I think it's such a tricky one, because I think we would all agree that we feel our staff are working really, really hard all the time to meet the targets, and yet often you still don't. You know, at the end of the day, it's about patient choice, isn't it? So you can show you've contacted everybody, you've done your recalls, you've done whatever you can to make it easy for them to access your practice, and yet still you don't do it. So, you know, it'd be great to hear if they've got some secrets that they want to share as to why they do it. Yeah.
I think because that, and I agree with you, Wendy, but then that would apply to every practice across the country, really. And the question for me is why we as a pardon?
Well, what are they doing differently to us?
Yeah, I think, and I have this discussion with my CEO colleagues. I think, and it's finding that right balance, isn't it? And your practice development facilitators will know some of this. It's finding the right balance between going into a practice and constantly be going on about the targets and how you're doing, and letting you get on with it and taking our foot off the pedal a bit. So if I talk to some of my CEO colleagues, and actually they have issues with relationships with their practices, because that's a lot of what they're talking about and pushing and doing. I think we've resisted that a little bit, because I don't want to be a PHO that's just going in as a sort of auditor and stick basher and saying, come on, let's get your immunisation targets up, let's get you smoking up, your smear level up. But it is an issue for us as a PHO, Pinnacle with a reputation for doing things really well. And as I've been saying here, it's no good as doing lots of innovative stuff if we're not doing as well as we could be doing on the BAU. We have to get the core basics right.
I think that's some of the challenge sometimes, because we are privately owned practices, and so you want to have the ability to do your own things that sit outside that. But yeah, knowing that sometimes what happens is that might get in the way of you then achieving targets. So it's hard to get a balance sometimes. Yeah, I think, if we're owned by the government, and that would always be your focus, I think. But we want to be able to do some other things and be responsive to our communities, and try and offer things that they're looking for, which doesn't always match with what the quality targets are.
Yeah, and I think there's a number of factors. So I don't think it's just one thing, and because we've got a lot of practices that put a lot of hard work into, as you say, doing what they can around those indicators, and they talk about it. I see the practices that have it on their visual walls and talk about it in huddles and where are we at and what do we need to do, tend to do better. I think it's also a symptom of how busy general practice has become and the complexity that practices are dealing with. But having said that, so is every other practice. It's when you see your PHO performance in relation to other PHOs, it becomes a bit more difficult to use reasons like that, because everyone's operating within the same context. But it is something I do think we need to address as a PHO, and there's a lot of work going on. I mean, I know the practice development team work with you all doing this, and I don't think there's one easy solution, otherwise everyone would be doing it. I don't think necessarily attaching more money to it works, because I don't think actually most of the people in our network are driven by the fact that they'd get more money. I think it's probably as working with each practice to say, what can we do? How can we support you?
It's definitely not about the money, particularly for our practice. We're so low in resources. Nurses are like gold. I can actually find doctors more than I can find nurses. So it's trying to have that mindset shift. So we're now moving towards employing HCAs to do a lot of the groundwork, because we are below in our immunisations, and we all feel really, really bad about it. It's something that no amount of money is going to change the views of this practice. We want our patients to all have their smears, all have their immunisations. So yeah, it's really tough at the moment.
Yeah, and I agree with you, Megan, and that's why I'm saying I think there's lots of reasons, and some of it's very practice specific, and that's why I'm very keen to get the balance right between, because I don't believe any of our practices sit there and think, oh, we're just not bothered about that. We haven't got one practice like that. So it's not that is the issue, because I think every practice it prides itself on its performance around things. So I think there's lots of issues that compound it, but the reality is that if you look across the PHO league tables, we're in nearly all of our DHB districts, we're not in the top quarter anymore.
Okay, do we have any more questions for Helen before we close for the session?
Was there anything that you wanted covered that wasn't covered?
Probably, Helen, just before we go, I just wondered, there was quite a big focus last year on mental health and funding that was going towards mental health and health improvement practitioners and that type of thing. There was lots to talk about that, and that I haven't sort of heard, is that gone a little bit now? Is that gone elsewhere, or is...
No, that's still, so that was a separate stream of funding that came down from the ministry. They're behind in their rollout of that for a number of reasons, not just COVID. So it's been rolled out. We're currently rolling out it in Taranaki, but again, it's being targeted to high need Māori populations. In the Waikato, where you are, Melanie, it's being rolled out currently, and it's being targeted at practices. The first tranche of practices that will receive that service are the practices who have got Māori populations of 40% or more.
Okay.
And this is what I'm saying, because that's almost been a change from when Jacinda first announced that funding to primary mental health. It's now being very much targeted at our Māori populations. Having said that, in the Waikato, over the next 18 months, every practice will be able to receive that service. It's just how it's being rolled out first. Okay. So no, it hasn't gone away. It's just the timing and the rollout has been delayed somewhat. And COVID was some of that. So by the end of next year, every Waikato practice should have access to that primary mental health service.
So just adding to what Helen said, we're supporting the rollout of this. We're not leading it. So we're, there's a whānau pai is what it's called in Waikato, and we're starting to be involved in discussions with practices right now. I've got a meeting at 2 o'clock with a practice where it's the actual operational side is being discussed. So there are practices, like Helen said, that have been targeted that have that high Māori population as in the first tranche. So it's just starting to appear at practice level now. So with those first tranche of practices.
Thank
So
you.
it's rolled out in Lakes. It's hasn't been rolled out in Tairāwhiti yet. I don't think we've got any Tairāwhiti practices here. And it's being rolled out in South Taranaki.
So for us, it's just a bit of watch the space for now.
Yeah, but they've said every Waikato practice will have access to the service by the end of next year. Yeah.
Okay.
So do you feel, how much time have we got left? Oh, we're nearly on time. It's nearly eating time. Do you feel that in terms of how we distribute the funding, that makes sense and feels right?
It makes sense, it just doesn't feel right. As in seeing the proportion that the DHB get compared
I see what you mean.
Yeah,
yeah, well,
it makes sense, but it's not right.
Yeah, well, you know, that's yeah, and it's interesting because it's not just New Zealand. It's in, you know, we could do another session on this. you know, every country that's got an established privately a general practice system has the same issue. But that's why we need, you know, we need to have loud, credible voices, and we have to be credible in terms of, we can't just stand there and ask for more money. We have to be very, very clear about what we would use that funding for. At one level I think that, and at one level I think, well, you just look at that graph and you don't have to be Einstein to work out that if you want a high performing primary care system and decrease the number of patients that are using expensive hospital services, you just fund it more.
It feels upside down, you know, when you think that general practice, what probably caters for, I don't know, 95% of the population that are enrolled in a general practice. So yeah, to me it feels like the money should come through primary healthcare first and then get filtered down as yeah.
And there is some,
yeah.
and there is, I mean, I don't want to hold you up because I could talk about this forever, but there is some discussion that with the establishment of Health New Zealand, that one of the options is that funding goes two ways from Health New Zealand. It will go one way to DHBs for hospital and the services that DHBs provide, and none of the primary care funding, and when I mean that, I mean for community services as well, will touch the DHBs. It will go directly to a PHO type organisation. So all those options are being looked at.
Okay, we have no more questions for Helen, people. I'd just like to thank Helen for delivering the session. I found it very informative as well. And no, it wasn't as boring as I thought it would be around funding. So I think that's really good as well. So, and it's quite interesting to see just how small chunk of pie we do get, but the amount of work that we do deliver on. So well done to each of us.
You do amazing stuff out there in general practice, which is why I would never work anywhere else, even where all the money is, even where the bigger pie is.
Yeah. Just to remember that the session is recorded, so at any stage you can revisit it to check at it. Helen Thomas, I hope you're still on to do a closing karakia for us, please.
Aye. So I'll just finish our hui, wrap it up with a karakia. Kia tau tō rangimārie ki runga I ngā iwi o te ao. That's just about letting peace reign and on all the people in the world.
Thanks, Helen.
Okay, thank you everyone.
Thanks, everyone.
Enjoy the rest of your day. Thanks.